I hope to refocus you a little bit, maybe away from LDL-C and cholesterol, which is what we typically focus on in preventive cardiology, which is basically what I do, trying to prevent cardiovascular events. Triglycerides have been characterized as a forgotten lipid. Most Americans do not know what their triglyceride level is. We did a survey at the National Lipid Association a few years back. 90% of Americans don't know what their triglycerides are, but they're very important markers and targets for cardiovascular risk reduction. So we'll show you some of that data. If you look at the overall prevalence of hypertriglyceridemia based on cut points in the NHANES data from 1999 through 2008, you can see that about 1/3 of U.S. adults have elevated triglycerides, if you define that as greater than or equal to 150. Realize a hunter-gatherer human will have triglycerides of around 50 their entire life, and these people do not get atherosclerosis as they age. So that's probably the normal physiologic state. So it's even a bit of a stretch to define triglycerides being elevated at a level above 150. You can make an argument even for going lower for that. But you can see about 1/3 of Americans have elevated trigs. About 1% of Americans have severely elevated triglycerides, that is greater than or equal to 500. And you can see a little bit of differences between the genders. Men tend to have a somewhat higher instance of hypertriglyceridemia. There's some evidence that trigs are more important in women in terms of driving factors behind cardiovascular disease. We'll show you a little bit of that data. And you can see some differences between different ethnicities. Non-Hispanic blacks tend to have less hypertriglyceridemia. It's roughly the same, maybe a little bit higher in Mexican Americans, for example. To put this in context, look at the use of triglyceride-lowering medication. Pretty low, even though there's a lot of hypertriglyceridemic patients in America. The AHA scientific statement on triglyceride classification, you can see what we define as a desirable trig is going down with time. We're now down to less than 150. We started much higher. Our definition of very high is now at greater than 500. The 2011 AHA statement classified triglycerides less than 100 as optimal. Okay, this is Michael Miller was the chief author on that. And if we ever had an ATP4, it was thought that this was going to be an important component of ATP4. So think of triglycerides above 100 as being abnormal. Optimal trigs less than 100. Where does this data come from? Where do we come up with this number? Well, the prevalence of small, dense LDL particles, highly atherogenic LDL particles, difficult to treat LDL particles, becomes much more prevalent with triglycerides above 100. Triglyceride-rich lipoproteins become much more common when you get trig levels above 100. So that's where that number comes from. Primary causes of hypertriglyceridemia, we're going to talk about genetic causes, which are uncommon, and then we'll go into the secondary causes. Relatively common, we've got familial combined hyperlipidemia. This is otherwise known as a hyper-ApoB state. And let me define what ApoB is. The lipid values that we normally look at when we say a triglyceride level is 100, that's the amount of triglyceride fat in circulation. That fat doesn't get anywhere unless it's in a lipoprotein. So all the fats, main fats we're talking about today are triglycerides and cholesterol. They are moved about the body, they are trafficked by lipoproteins, which are combinations of protein and lipid. So ApoB is a ligand. It is the apolipoprotein that sits on all of the atherogenic lipoproteins. So your LDLs, your VLDLs, your IDLs, et cetera, they all have one ApoB. It's a one-to-one relationship. So hyper-ApoB state means that your liver is putting out an excessive number of atherogenic ApoB lipoproteins. This is a genetic abnormality. There's no single gene abnormality that accounts for this. As you can see, there's a variable phenotype. In most people, we're going to see increases of both trigs and total cholesterol. This is a highly atherogenic state. These are folks that have a very strong positive family history of premature cardiovascular disease. Contrast that with familial hypertriglyceridemia. In this state, the triglycerides alone are elevated. Cholesterol is usually normal. This is only associated with cardiovascular disease if you have an overlying insulin resistance syndrome, like metabolic syndrome or PCOS. So in this case, ApoB is normal, because that's a relatively benign state in most cases. And then there are some even rare deficiencies like LP, lipoprotein lipase deficiency, where you're not going to handle your remnants properly and they're going to build up in the bloodstream, very high chylomicron levels, for example, and a couple of other rare genetic disorders, the Friedrichsen-Levy type, this beta lipoproteinemia type 3. Much more commonly, we see these secondary causes of hypertriglyceridemia, which always need to be addressed whenever you look at a patient with high trigs. So positive energy balance, increased carbohydrate intake. When sugar is broken down, you create glycerol, which is the backbone of a triglyceride molecule. So what is a triglyceride? It's basically 3 saturated fats, 3 fatty acids attached to a glycerol backbone. So anything that increases your sugar intake causes insulin resistance. You're going to get more glycerol. Triglycerides are going to go up. So increased glycemic index content. Fructose is the most lipogenic of all sugars. That's why high fructose corn syrup has been demonized recently, and appropriately so, because we consume a lot of fructose, you're going to put out a lot of ApoB, triglyceride-rich lipoproteins from your liver. Adiposopathy, in lipidology, we now finally have our own opathy, like all the other specialties have. So adiposopathy would mean a genetic abnormality where your adipocytes cannot handle carbohydrates properly. It's associated with central visceral adiposity. It's associated with increased risk of cardiovascular disease and diabetes. Diabetes mellitus, if your diabetes is not well controlled, you're never going to control your triglycerides. If your hemoglobin A1C is above 8, it just isn't going to happen. Hypothyroidism, even subclinical hypothyroidism, where the patient feels fine, but the TSH might be between 4 and 10, let's say. That leads to abnormalities in how your body handles triglyceride-rich lipoproteins. You don't process them properly. They tend to accumulate in the bloodstream, get into the arteries, and cause clinical disease. Nephrotic syndrome, different mechanism, but same end result. You tend to pile up triglyceride-rich lipoproteins in the bloodstream. And then medications, there's a long list. We just have highlighted some here, more common causes in yellow. Older non-selective beta blockers, thiazide diuretics, probably not in the doses we use these days. 12.5 milligrams of HCTZ isn't going to do too much in my experience. Oral estrogen does a lot, particularly conjugated equine estrogens. One of the most common consultations I get is triglycerides are up. Why? The patient's on an oral estrogen. Switch them over to transdermal preparation, the trigs fall dramatically. And then tamoxifen and even raloxifene has rarely been reported as causing hypertriglyceridemia. Bile acid sequestrants can raise trigs. Interestingly, they don't raise ApoB, they lower ApoB. Cholecalciferol, for example, cholestyramine actually lower ApoB, even though the trigs may go up a little. Glucocorticoids, isoretinoin, some of the antiretroviral regimens, et cetera. And then recreational drugs, alcohol and marijuana can cause increases in triglycerides. Let's look at the association between BMI and hypertriglyceridemia. Basically, as your BMI increases, it becomes easier to have high trigs. The percentage of folks with high trigs goes up dramatically as your BMI goes up. A lot of that BMI will be in the form of visceral adiposity, and those are the patients where you really get a big triglyceride response. Cardiometabolic risk is one of my, favorite terms of my career in the last 10 years. I like it because it links together the most common cause of cardiovascular disease today, which is going to be insulin resistance. If you look at patients being discharged from the emergency room at Johns Hopkins or being discharged from the hospital who've had an acute coronary event or stroke, high percentage, 75, 85%, are insulin resistant. So there's a big link between insulin resistance and cardiovascular disease. And you could see some of the various phenotypic manifestations of that: high blood pressure, high triglycerides, high LDL-C, low HDL-C, et cetera. I think of it this way: when you get enough visceral adiposity, and if you're genetically predetermined, you get a toxic stew of adipocytokines in the bloodstream that cause all of these phenotypic manifestations. And certainly we can reverse that metabolic engine by making our patients more insulin sensitive, by losing weight, following a low glycemic index diet, and by exercising more. Metabolic syndrome, I'm not sure if you're familiar with this definition, but we'll go over it. This is the ATP3 definition. You have to have 3 or more of the following 5 risk factors. And as you get more and more of these risk factors, the number of ApoB particles go up. The amount of triglyceride-rich lipoproteins usually goes up. Your cardiovascular risk goes up as you become more and more dysmetabolic. So abdominal obesity, we can define that as greater than 40 inches in men, greater than 35 inches in women. If you have a small-bodied South Asian population, we lower these numbers. They become insulin resistant at a lower waist circumference. Triglycerides greater than or equal to 150. HDL-C less than 40 in a male, less than 50 in a woman. blood pressure greater than or equal to 130 over 85, and a fasting glucose greater than or equal to 100. So 3 of these 5 factors. There's some evidence to support that the triglycerides and waist may be the most predictive of these factors defining metabolic syndrome. Now look at the relationship between metabolic syndrome and cardiovascular disease outcomes in a MIRACLE trial, which was an early atorvastatin trial. So if you have metabolic syndrome, basically your cumulative hazard ratio is higher. So the presence of metabolic syndrome, a dysmetabolic syndrome, an insulin resistance syndrome, increases the number of events, increases your hazard ratio, even though you've aggressively lowered cholesterol. So there's a residual risk here that's exemplified in this insulin resistance syndrome we define as metabolic syndrome. If you look at hypertriglyceridemia and event-free survival in patients who've had a revascularization, who've had a PCI, if the trigs are low, you have a greater event-free survival. If your trigs are above 150, you're having more events. Your survival is less. So even though we've treated these people with revascularization, if their trigs are high, there's a residual risk. Again, when we identify residual risk, we can treat it therapeutically, which we'll talk about in the second talk today. This is the SARWAR meta-analysis, a landmark study that looked at about 250,000 patients and helped establish the fact that triglycerides are an independent risk factor for cardiovascular disease. They looked at tertiles of triglycerides. The top tertile was defined as greater than 181. The lowest tertile was less than 120. So triglycerides are an independent risk factor. You can see in women, maybe it's a little bit stronger of a risk factor, although the confidence intervals overlap in this meta-analysis. You can look at fasting versus non-fasting hypertriglyceridemia. There are studies showing that non-fasting triglyceride levels may be even more predictive. You get that postprandial bump in your trigs, and these triglyceride-rich lipoproteins after you eat cause a lot of endothelial inflammation, can cause an increased number of events. So that's an active area of research also. There's a connection, as you'll see, and we'll talk about the pathophysiology of this in a moment, but there's a connection between high trigs and low HDLC and vice versa. It's kind of a yin-yang type phenomena. And there's been a question for a long time, are triglycerides independent predictors of risk? Are they independent from HDLC? And the answer is yes. You can see when you adjust for HDLC, you attenuate the risk a bit, but the triglycerides remain as an independent risk factor. The overall CHD risk ratio is roughly twofold. So when you have hypertriglyceridemia, you're basically doubling your cardiovascular risk in this meta-analysis. The concept of residual risk in major statin trials, we're reducing maybe 1/3 of events at best in statin trials. What happens to the other 2/3 of the people? I want to prevent all or most of the cardiovascular events in my patients. It's not acceptable to just say we're preventing 1/3 of events and let's just leave it alone. So we need to identify risk factors that are causative agents for this residual risk, and triglyceride elevations are a big cause of residual risk. This is a pro versus con slide. Can hypertriglyceridemia alone cause atherosclerosis? Well, we've got some arguments against that. The epidemiologic data is not as great, it's not as numerous. Linking hypertriglyceridemia to increased events, it's certainly weaker than LDL-C. There's some attenuation when you factor in HDL-C. When you have severe hypertriglyceridemia, meaning trigs above 500, the trigs are often in chylomicrons, usually in chylomicrons then. And chylomicrons are too big to get into the party. The party is in the subendothelial space. That's where atherosclerosis occurs. The chylomicrons are far too big to get in there. So when you see someone with my high record for triglycerides is 10,000, I think the lab just got tired of counting and just rounded it off. When it got that high, that person's not at risk for cardiovascular disease, they're at risk for pancreatitis. Severe hypertriglyceridemia from chylomicrons hasn't been related to cardiovascular disease. You don't see triglycerides in atherosclerotic plaque. You look at a patient with plaque and look at it post-mortem and stain that plaque for triglycerides, they're not in there. The presence of hypertriglyceridemia indicates an atherogenic state, but the trigs themselves are often not found in the plaque in any great abundance. And then triglyceride-lowering drugs have not completely been proven to lower cardiovascular events. We've had some fibrate trials that didn't do well. We've had some niacin trials that didn't do well, et cetera. The data is not as clear-cut as it is with statins, for example, and LDL-C lowering. Now, here's the pros counterpoint. Triglyceride-rich lipoproteins are atherogenic. The triglyceride-rich lipoproteins, the VLDLs, the IDLs, the triglyceride-rich LDLs, they get into the subendothelial space. Triglyceride lipolysis by lipoprotein lipase generates pro-inflammatory free fatty acids. So you're going to get the creation of inflammation, which will weaken the endothelial ability to keep out other bad lipoproteins. Hypertriglyceridemia causes atherogenic changes in LDL and HDL. We'll see that in a moment. You infiltrate HDL and LDL with triglycerides, they become more atherogenic. Triglyceride-lowering drugs decrease cardiovascular disease in certain subsets of these trials. I said overall, some of the trials using triglyceride-lowering drugs have not been successful, but if you look at the subset of people with high trig, low HDL-C phenotype, that's where the drugs succeed. The fibrates, for example, consistently have been shown to reduce events in that subset of their trials, of people with high trigs, low HDL-C. We also will see this in the JLIS trial with an EPA-enriched omega-3 fatty acid in the second part of our talk today. So if you look at that subset, that's where the trig-lowering drugs work. And then trigs 100 to 800 is often associated with the hyper-ApoB state. Remember, the biggest reversible cardiovascular risk factor is hyper-ApoB state. You have a lot of ApoB lipoproteins in your bloodstream, they're going to get into the subendothelial space. It's a simple concentration gradient. You have a hyper-ApoB state, those lipoproteins are going to get into the subendothelial space, provoke plaque formation, provoke inflammation, provoke clinical events. These particles are going to get to the party and cause havoc. Baseline triglyceride levels predict 5-year risk in statin-treated patients. You can see in patients who have high triglycerides in these 3 different studies, heart protection study and then the CARE lipid studies together. When the baseline trigs are elevated, you have greater incidence of cardiovascular events, even though you're on a statin. If you look at the PROVE-IT trial, what PROVE-IT was a trial of more potent atorvastatin versus weaker pravastatin and really showed that more aggressive LDL-C lowering reduces events. If you look in this trial, triglycerides remain as a risk factor even after you get the LDL-C down to fairly low levels. So if you get the LDL-C down to less than 70, you can see the trigs are still predictive of risk. A very well-treated patient, no matter what drug they're on, if their LDL-C is less than 70, their trigs are still up, they have a greater risk of an event than if their trigs are lower. And this suggests that maybe we shouldn't just target LDL-C. Maybe we should target both LDL-C and trigs. That may be an important therapeutic strategy in patients after ACS. This ugly-looking coronary artery is what we're trying to prevent. The mission that we have as clinicians is to look at every patient and say, does this patient have abnormal lipoprotein trafficking, regardless of what their LDL-C level is? You can have abnormal lipoprotein trafficking with an LDL-C of less than 70. Mr. Tim Russert paid for his life with that. It's a famous example. So you can have a well-treated LDL-C and still have abnormal lipoprotein trafficking. How do those sterols get in there? They get in there when you have too many ApoB lipoproteins. The key initiating process in atherogenesis is the subendothelial retention of ApoB-containing lipoproteins. Again, you have a lot of ApoB-containing lipoproteins, they're going to get in there. It's a simple concentration gradient. You don't have a lot of them, you're not going to have atherosclerosis. You could take a lab rat and make him hypertensive, you can make him smoke, you can make him fat, you can make him lazy. Unless he's got a lot of excessive ApoB lipoproteins, he's not going to get atherosclerosis. You can have all the inflammation in the world. There's a lot of talk about inflammation and atherosclerosis. Inflammation merely opens the floodgates, allows more ApoB lipoproteins to get in there. If you don't have a lot of them, you're not going to get events. So here are the lipoproteins, the vehicles, if you will, that transport the fats through the body. What happens, the ApoB lipoproteins are on the left, VLDLs, IDLs, and LDLs. When they're eaten by a macrophage, it turns into a foam cell, which then causes plaque formation. Obviously, the plaque will become inflamed eventually. It'll blow up, and you'll have a clinical event. In the lower right-hand corner, we have the ApoA1 containing lipoproteins. This is HDL, which obviously is cardioprotective. So you have an excessive number of ApoB particles, your bad things are going to happen. Non-HDL-C is a very cost-effective and simple way to count all the atherogenic lipoproteins. We tend to focus exclusively on LDL-C. This is a historic bad habit we've gotten into. And LDL-C worked great as a risk predictor when everybody was insulin sensitive. You know, if you watch old TV shows like I do once in a while, everybody's skinny. Look at Mayberry RFD and the Andy Griffith Show. Everybody but Aunt B looks pretty skinny. Well, now we're starting to look a lot more like Aunt B, unfortunately, right? We're getting a lot of visceral adiposity. I don't mean to pick on Aunt B, I'm sorry. We all love Aunt B, right? But I'm guessing she didn't live as long as Andy. I don't know. Now we can't rely upon LDL-C anymore. The composition of these LDL lipoproteins changes as the triglycerides go up and you become insulin resistant. So LDL-C is losing its power to predict cardiovascular disease. And we now have a very simple tool, non-HDL-C, which is a simple arithmetic equation, non-HDL-C, total cholesterol minus HDL-C. Using my own example, total cholesterol 150 minus an HDL-C of 55 gives me a non-HDL-C of 95. That number encompasses a way to count all of the atherogenic lipoproteins, not just the LDL-C. So we're encompassing the VLDL-C, the IDL-C, Lp(a), which we won't talk about today due to a lack of time. So non-HDL-C is a better predictor of cardiovascular events. And it's not widely available in every lipid panel. It should be, and it's certainly easy to calculate. So let's look at why this is a better predictive factor. Here's a couple of examples for you. Patient comes in and says, Dr. P, my LDL-C is 130, what do I do? You look at the rest of the lipid panel, here the trigs are less than 100, HDL-C is barely adequate. You know, this person, because of this trig to HDL-C ratio, if this ratio is less than 3 to 1, you tend to have big, fluffy LDL particles. It doesn't take as many big, fluffy LDL particles to carry 130 milligrams of cholesterol. The non-HDL-C is 148, which you'll learn is modestly elevated. A non-HDL-C above 130, I would consider to be at risk. Contrast that with this situation. Second patient comes in and says, Dr. P, my LDL-C is 130. What do I need to do? This patient, same LDL-C. However, here the trigs are elevated. HDL-C is low. This is the most common atherogenic phenotype we see in America today. High trig, low HDL-C. Here the ratio is far greater than 3 to 1. It's about over 8 to 1. And over 3 to 1 trig to HDL-C ratio, you know that you have small, dense LDL, you have a lot of it, and you're insulin resistant, most likely. You know that with at least 80% certainty. So here we have a lot more ApoB lipoproteins, and you can see here the non-HDL-C is correspondingly much higher. So note, again, that your non-HDL-C correlates with an overabundance of more ApoB. A high non-HDL-C correlates with an overabundance of ApoB particles. This person is at much higher risk for a cardiovascular event than this person. Many more ApoB particles. The risk travels with the ApoB particles, regardless of the LDL-C. Most American physicians are treating these two patients types identically. We're missing the boat. This is an opportunity to identify residual risk, try to normalize this lipid panel, reduce the number of ApoB particles. Our most complex slide. What is the pathophysiologic basis of why hypertriglyceridemia is associated with increased cardiovascular risk? When you have central visceral adiposity, the adipocytes start to malfunction. They leak free fatty acids, which hitchhike a ride on an albumin to the liver, and you're going to make triglyceride-rich lipoproteins. VLDLs will be synthesized. If you're getting fructose, glucose, and various other simple sugars coming in from the liver, that'll facilitate this process. Also, the liver will put out an increased number of VLDL particles. Oral estrogen does the same thing, for example. Many of the pharmacologic causes of hypertriglyceridemia will cause the same process. Alcohol does the same thing. Similar mechanism, too many VLDL particles excreted from the liver. What happens when the trigs are above about 130, they'll flow down a concentration gradient into the LDL particles where they don't belong. In nature, in a hunter-gatherer with trigs of 50, you don't get this. When trigs are much above 100, CETP will facilitate the swap of triglycerides for cholesterol. You'll get a cholesterol-enriched VLDL, so the VLDL-C will go up. You'll get a triglyceride-rich LDL. This triglyceride-rich LDL will attract hepatic lipases, which will break it down to a small, dense LDL. These small, dense LDL don't bind to the LDL receptors as well. They accumulate in the bloodstream. They can get into the subendothelial space and wreak havoc. ApoB goes up. ApoB is born on a VLDL and it stays on an LDL for its entire lifespan, so ApoB will go up. On the HDL end of things, you get the same thing happening. Trigs much above 100, they flow downhill into an HDL particle. They're swapped for cholesterol ester. You get a triglyceride-enriched HDL particle. Doesn't function well. Triglyceride-rich HDLs become dysfunctional. They don't perform their normal anti-atherogenic functions. They also shrink down. When you get a triglyceride-rich lipoprotein, it attracts hepatic lipases, shrinks the particle down. These particles are more rapidly catabolized at the kidneys. You lose atheroprotective ApoA1. You want to know where the HDL is going in a hypertriglyceride-rich patient, do an ApoA1 assay on a urine. It's in there. So now you understand, hopefully, the reverse relationship between trigs and HDL. The HDL-C will go down because you have smaller HDL particles, and the remaining HDL is dysfunctional. So you get this atherogenic dyslipidemia. Trigs are up, VLDL-C is up. You get small dense LDL, the ApoB and LDL particle counts are up, highly atherogenic. And your HDL, you're losing some of the anti-atherogenic properties of your HDL. So this is the triple whammy of the atherogenic dyslipidemia. Why do we want to use non-HDL-C? In the presence of high triglycerides, greater than 200, non-HDL-C is better to assess atherogenic risk because it's going to encompass all those other particles that we mentioned. It doesn't focus exclusively on LDL-C. Unlike calculated LDL-C, non-HDL-C can be accurately measured in non-fasting patients. I use it as a screening tool in high school sports physicals in patients when they come in. It might be their first lipid panel ever. Non-HDL-C is highly correlated with total ApoB. So non-HDL-C has been characterized as the poor man's ApoB. It's not exactly as accurate as an ApoB, but it's a lot more accurate way to assess atherogenic risk in 2013 than an LDL-C. ApoB, again, biomarker with a strong predictive power for severity of coronary atherosclerosis. Throughout the rest of the developed world, ApoB is a risk assessment tool and a goal for treatment. The United States lags behind the Canadians and Europeans in this. Non-HDL-C, again, is a simple calculation, so there's no additional cost. Just takes a second to calculate. The Framingham study shows us that non-HDL-C is superior to LDL-C in predicting risk. If you look at a given non-HDL-C level, there's no association between LDL-C and CHD. So let's pick a non-HDL-C of less than 160. You can see that the LDL-C risk is kind of flat. You can see this if you look at a non-HDL-C of 160, cardiovascular risk is flat. At a given non-HDL-C, the LDL-C doesn't predict risk. However, if you look at the reverse, non-HDL-C predicts cardiovascular disease at any LDL-C level. Let's say you're a patient with an LDL-C less than 130. As your non-HDL-C goes up, your cardiovascular risk goes up. It's a much steeper gradient. So non-HDL-C, you can see, predicts risk much better than LDL-C. That's a much stronger CHD risk predictor. Again, non-HDL-C is free. You can get it. It's in every lipid panel. We could really make a difference. There's actually some cost-benefit analyses out there that we could save up to 500,000 U.S. lives in the next 10 years if we move to a non-HDL-C paradigm instead of our existing LDL-C paradigm. What are our targets? Okay, these are ATP3 targets. If you have no CHD and less than 2 risk factors, your LDL-C target is less than 160. You can see that the LDL-C target goes down as you accumulate risk. The non-HDL-C target is 30 milligrams higher. So at every level, if you have a patient as a diabetic where automatically your LDL-C goal is less than 100, the non-HDL-C goal is less than 130. Many patients are treated to these levels. This is what most physicians do, but the majority of American physicians are not doing the second step. They're not calculating non-HDL-C. They're not paying attention to that. Triglyceride lowering is a big part of lowering non-HDL-C and getting the patient to that goal. We're doing a lousy job as practitioners of getting patients to goal. As you can see, we're not getting a high percentage of patients to goal. We're doing an even worse job of getting patients to non-HDL-C goals, or getting people to both goals, as you'll see here in blue. These are the percentage of patients not getting the goal, so higher is worse. Interestingly, the higher the risk to patient, the poorer the job we're doing, you can see in general. So we're just not doing a good job of getting people to goal. We need to rethink our strategies. They're not working. Here's a case, a 49-year-old woman with diabetes, controlled on metformin and a statin. BMI is 29, blood pressure is fairly well controlled, waist is 41 inches. You can see she's on metformin, aspirin, and atorvastatin. Here's her labs, A1C 6.5, total cholesterol 177, trigs 550. When you see that trigs above 500, that becomes your priority for treatment. You stop. I don't even look at the rest of the lipid panel at that point. When you see trigs above 500, you know the patient is at risk for pancreatitis. We need to address that, and that becomes our primary target. So let's look at the risk assessment. Age is a positive risk factor here, being over 45. It's a primary prevention patient. Diabetes, we know, is a CHD risk equivalent. You should look at every diabetic as if they've already had an MI, particularly women, in terms of your risk assessment. In terms of metabolic syndrome features, basically we have 4 out of 5 features of the metabolic syndrome. Remember, the more features of metabolic syndrome you have, the greater your risk. Again, sticking out like a sore thumb, the trigs greater than 550, so we have to address that as our top priority from a lipid management. What's the most concerning feature of her lipid profile? Is it the A1C, the trigs, the LDL-C, the HDL-C, or the non-HDL-C? Treatment recommendations for elevated trigs. Once you get trigs above 200, in addition to our therapeutic lifestyle changes, and realize trigs are very responsive to therapeutic lifestyle changes. Once you get into this range, you need to consider your non-HDL-C goal, and you need to consider pharmacologic intervention. Statins are highly effective at lowering LDL-C. You might want to add in niacin or fibrate. You want to reduce simple carbohydrate intake. Once your trigs are very high, you're greater than 500, in addition to your usual therapeutic lifestyle changes, you're going to shift. Because here we're talking about chylomicron disease, and we're going to have to reduce the saturated fat intake or the total fat intake. Remember, chylomicrons are made in the gut. When you have chylomicron disease with very high trigs, you want to reduce fat. When you have triglycerides in this range, you want to reduce sugars. We're going to add niacin or fibrates, or certainly we can use pharmacologic doses of omega-3s as per their FDA indication. Again, triglycerides greater than or equal to 500, our top priority is reduce the trigs to prevent acute pancreatitis. So despite effective LDL-C lowering therapy, there's significant atherogenic residual risk remains. We're not going to fix everybody with a statin. We're not going to prevent all disease. Triglyceride assessment is important to evaluate for cardiovascular risk. Elevated trig levels are associated with increased cardiovascular disease risk, particularly that phenotype of high trig, low HDL-C, and they contribute to the atherogenic dyslipidemia. Non-HDL-C is highly correlated with LDL particle counts, ApoB, atherogenic particle counts. It's a better and more easily obtainable marker for atherogenic cardiovascular risk than LDL-C. There's no reason why we shouldn't be doing this in every patient. Thank you very much for your attention.